Hello everybody, my name is Kraztik. I'm from the Urological Department of the Medical University of Vienna, and it's a pleasure for me to talk on behalf of the Hamdan Medical Journal to you about the prostate cancer, the importance of testosterone. Dealing with the subject, this slide is obligatory. Without these men, we wouldn't talk about the relationship of prostate cancer and testosterone. Here it started. That's the second mainstay. Without these men, we wouldn't have been able to apply LH-RH analogues or antagonists in modern medicine, because they found that the peptide hormone production of the brain is responsible for all other hormone ways in our body. But this is not only a question of hormones, it's also a question of enzymes, and that's the third mainstay. Here we found out that 5-alpha reductase, an enzyme, is important in transforming testosterone to dihydrotestosterone, the most potent androgen we know in our body. We will deal with a couple of enzymes later on. We had to learn our lessons. First, as we applied LH-RH analoga, we didn't know that it will come to a testosterone surge, the so-called flare-up. And there, these patients had a risk of fracture and paraplegia if they had metastasis in the spine. Nowadays, we know this problem, and we give to all these patients anti-androgens before. If we measure testosterone in the serum, we should keep in mind that's just a surrogate measurement, because the interprostatic hormone levels are much less. Nevertheless, it's quite interesting. Here you see tissue sources. Testosterone in benign prostate hypertrophy has about 0.04 nanograms per gram of tissue. And if you look at the cancer, it's about 6 times that amount. And in metastatic tissue, it's about 20 times that amount. And this is in castration-resistant prostate cancer patients. Well, let's have a look at the story how prostate cancer develops. First of all, it's organ-confined, locally advanced, then disseminated. And we will talk about the hormone castrate-independent carcinoma. And we also found out in the last couple of years that late-stage prostate carcinoma remained driven by androgen receptor signaling. So this gave rise to a change of the nomenclature from androgen-independent carcinoma to castration-resistant carcinoma. Let's have a closer look what is happening there. We do have the androgens. They get into the cell, bind to the androgen receptor either directly testosterone or by splitting testosterone via to the hydrotestosterone via the 5-alpha reductase. This complex gets into the nucleus, there binds to the androgen-responsive elements, and then PSA goes up, cell goes up, and survival is guaranteed. Let's have a closer look at the whole thing. What happens in castration-resistant carcinoma? We have, first of all, the androgen receptor, which is amplified, which can be a sort of promiscuous pathway. It can be an outflow pathway, can be bypassed, or it can act via the co-activators. And this line shows you above there, we deal with androgen receptor or testosterone. And down there, probably we don't need them so much, but still there's a need for testosterone, as you will see later. Let's have a closer look at that now. Here you got the amplification. The more androgen receptors are present, the easier it is for them to find even the last bits and pieces of testosterone. We have a second possibility. The androgen receptor gets a gain of function and is now responsible, responses able for other steroids. There's another possibility the cell has gained. It can make a local androgen production and synthesizes from adrenal androgens or cholesterol testosterone. There we need a next enzyme. That's CYP17. Here you can see the pathways. That's the conventional pathway, and that's in bold italics the backdoor pathway, how the cell by itself can produce testosterone if there is an androgen deprivation on its way. This is just to show you that from a paracrine mechanism in normal homeostasis in the androgen-dependent cell, it is going over to a paracrine mechanism, so the phases of these pictures changes. Then we got the ligand-independent activation, as you see here. That's the P10 mutation. You have seen that already in the talk of Professor Zielinski, where the P13K pathway is activated or the MAPK pathway is activated, but still we depend on an androgen receptor. That's how modern drugs get into this game. We block the enzymes, and we can do that by arbutin acetate, so that's the second hormone way. It inhibits CYP17, and therefore it interferes with steroid biosynthesis. It is already approved with prednisone in metastatic castration-resistant prostate carcinoma, and there are different trials going on or being evaluated already. And here you see the last trial, and there you have a difference of 4.6 months, giving a better overall survival to patients treated with arbutin acetate after conventional chemotherapy. Well, let's have a closer look. This was as it began, surgical orchiectomy. Here was the second chapter, the blockage of LH-RH. There is now the third chapter, the hormone production of the adrenal gland, which is blocked by arbutin acetate. Now we get on to the blockage of the androgen receptor by itself. MDV 3100 is an androgen receptor inhibitor which is really strong and more potent than the known bicalutamide. It binds the amplified or overexpressed androgen receptors. It disrupts the nuclear translocation of androgen receptors, and it impairs the DNA binding to the androgen response. There are two studies, one in chemo-naive patients and one in post-chemo setting. And enzalutamide, as the substance is called now, this study, the AFFIRM study, after chemotherapy has been completed yet. And here you see also survival of more than 4 months better with the substance than with placebo. And you also can see what is happening in PSA. Are there any future perspectives in dealing with testosterone? Yes, there are. Well, blocking the receptor, testosterone goes up. Blocking testosterone, the receptor stays high. So the next step probably would be to combine those two to find out what's happening then. And this might be of future relevance for the patients. But there are also other future perspectives. If we look at the androgen receptor, we see the LBD, the ligand binding domain, that's the hinge, and here the N-terminal transactivating domain. All our therapeutic modalities we have up to now deal with the LBD. We don't touch the N-terminal transactivating domain, which is one of the most important because that's the engine of the androgen receptor, as Sada called it. And there are now substances, small molecules coming up that block and the N part of the receptor, and also giving hope of new possibilities for cancer patients. Well, what is testosterone? Testosterone promotes prostate carcinoma, as I've told you by now, but can it inhibit prostate cancer, and if so, how come? Well, 12 years ago, you see R1881 is a very potent synthetic testosterone. And this is an animal study. And if you apply R1881 to these animals, it brings down the growth rate of prostate cancer cells. The same happens with dihydrotestosterone. Here you see the control group. This is a review from 1981. The response of metastatic adenocarcinoma of the prostate to exogenous testosterone. They had 52 patients, and 7 patients experienced a symptomatic benefit by adding testosterone in metastasized patients. So how can this be? In 2009, there was a phase 1 trial of high-dose exogenous testosterone in patients with castration-resistant metastasis, and you see, in certain patients, it was possible to bring PSA down, and PSA is a common marker for prostate carcinoma. In the same year, replacement for patients with low-risk castration-resistant prostate cancer, well, also a certain proportion had fared better by applying testosterone. Well, you all know that. That's the cell cycle, and in G1 phase of the cell cycle, we should apply our therapies. We know that from our friends from radiation therapy. We know that from oncologists. If all cells would be in the G1 phase, that was the best setting for them to apply their therapies. This can be due to the fact that, or is due to the fact that in G1 the DNA replication starts. You need a replication here to be started, and only here and only once, so that 4 DNA strands result in here to get into the mitosis, and then you have 2 cells. You are not allowed to have more than 4 DNA strands. So a reduplication is not possible. You can't start at one end of the DNA just to the other end of the DNA because it's too long. So you need, and it would be much too time consuming, so you need sites of origin where you start the reduplication of the DNA. There are about 2,000 for the DNA strands where reduplication starts. Well, that's the site of origin, and to get that started, you need a substance or a so-called licensing factor telling the cell, now start reduplication of that part. This happens in G1 phase, in the early G1 phase. There is the restriction point. Thereafter, this licensing factor, which is bound to the origin of the duplication complex, you see that here, has to be degraded. If it's not degraded, you get a reduplication, and therefore more DNA strands, which would lead invariably to an S phase arrest, and then that's the end of these cells. And the interesting thing is, and this explains all that what I've shown you before, that testosterone per se is a licensing factor in carcinomatous cells. That's the normal prostate, but in carcinomatous cells, the androgen receptor can act as a licensing factor and has to be degraded then thereafter. If not, you get the S phase arrest. And that's also why the intermittent androgen blockade is working, and that's the molecular concept for the whole thing, because if you stop the degradation of the androgen receptor in a certain point in late G1 phase, then you kill cells. And that's happened to all these patients where we have seen the clinical benefit. Well, that's, and I'm a urologist, that's the evolution of the surgeon scientist. We needed anatomy and then the pathophysiology. But in future, we also will need the molecular settings to find out what is best for our patients, whom to operate on, and who is a better candidate for alternative therapies, chemotherapy, or targeted therapy. Thank you very much for your attention.